Good morning, everyone. I think the reason for this topic today was one of the cases that was presented a few weeks ago, and the topic of this posterolateral decompression technique was brought up, and uh, I was asked to sort of give a little description of this technique, although uh, many of you may know, but the detail of it, I think it might help. It's kind of historical uh, um, talk because it, it 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 was all in the slides, and thank you, Hazem, Dr. Al-Sabai, to help me out to transfer it to PowerPoint. And It was presented, I think, in was developed in late 80s and uh, presented at SRS in 1994, I think. And then I just wrote some chapters in Dr. Bridwell's book and other books. So it is basically a review of a technique. I'm not going to be talking about a lot of uh, uh, data, recent data, but it was the series that was presented at that time. Um, if you look at the burst fractures and look at the Frankel grade versus sort of encroachment of the canal, you're using perhaps other methods rather than Frankel, but Frankel was very common. We used it a lot, and from A to E, and E is the intact patient, and A is the complete. And you can look at the range of encroachment. You can see pretty much, all of the levels regarding, the total neurologic uh, uh, deficit or intact. They were having a fairly uh, wide range of canal encroachment. So there is no correlation between the canal compromise and the neurologic deficit. We know that. We also know that the remodeling happens in some of these patients, especially in the younger patients, and maybe depending on the location and the size. This is a patient who, in a year, completely remodeled the spinal canal. So that has to be considered as well. The techniques of decompression is either indirect, either anterior, posterior, posterolateral, or combined. The indirect decompression is like something like this: that the patient had a fracture dislocation, and by using the Harrington technique and distraction, there was a reduction, and therefore there was no need for decompression directly. This patient, in fact, was intact, and went very well. The anterior decompression, this is an example of anterior decompression, and using Canada instrumentation, short fusion anteriorly, and you can see that the canal has been decompressed, and usually use the iliac graft, and I used a lot of allograft, which gave very good fusion at that time in the series that we presented in a matter of a year afterwards. You can see the test. However, the posterolateral decompression technique has some advantages. Posterior approach is more familiar for surgeons, spine surgeons as well. Um, and the stabilization of the spine can be done at the same time. Um, Many times, like the case that was presented a few weeks ago, we have some laminar fractures that increases the risk of dural tear, and the dural tear could be repaired at the same time that decompression and instrumentation is all done at one approach. Um, but if there is still some uh, uh, compression there, then that could be done as a second stage, going anteriorly and do a decompression. But some disadvantages as well. It's more feasible for lumbar spine injuries rather than thoracic, perhaps. Uh, doesn't provide adequate strut grafting for severe kyphosis. So those that really are kyphotic and requires a strut grafting between two segments may not. But if you reduce the fragment and only require the grafting of the disc, this is perfect. The old injuries that cannot be corrected, probably is better to have it anterior decompression. uh, is pretty much like congenital kyphosis. The key points in the technique is it's a unilateral approach. There have been, prior to this, there have been techniques that going from both sides really make it more unstable. There was techniques that go through the pedicle like a tube, which doesn't give you a good and adequate exposure. Uh, but this requires unilateral approach. It requires a complete removal of the pedicle, so you can get a good access to the dura without really pressing it, and also the fragments. Um, and then obviously decompression of the vertebral bone fragments anterior to the dura and removal of the disc and interbody structural grafting, which I would go in a few minutes. The steps on the technique is like I call 7 steps. Identify the site of decompression ahead of time, and that's for this amount or significant neurologic deficit, if it's right or left, or also from imaging to see what is the main or more fragments in the right side or the left side. So once that is identified, then one side, the other side, the opposite side could be stabilized. And many times you can go with short fusion because we always use the other side of the fractured vertebra to put a screw. So it would be 5 screws if we have a short fusion. If you have, especially if you have an anterior grafting. The next step is to osteotomize the transverse process, and that would be by just taking a rongeur and taking the posterior cortex of the transverse process, and then use in the base, and then use the kerosene rongeur to get the posterior cortex of it, and then just leave it floating with some of the soft tissue attached to it already. Remove the lateral cortex of the pedicle. You can use either burr or rongeurs, and but leaving the medial cortex of the pedicle intact, and that would stay throughout the few steps to make sure that the dura is protected. Then using special instruments, decancelize the vertebral body first, going through the pedicle into vertebral body, and have a vacuum there, a space there to be able to reduce the fragments. And then the disc above, the end plate above, and the disc will be cleaned with the disc from the disc material with the special curette. And the next step would be then remove the medial cortex and protect the dura, and then reduce the fragments. And the final stage is the interbody structural grafting, and then completing the instrumentation. The instruments that was developed for this was this. I think Greg has the instruments now. I was trying to see in the office, but I think he has it. It has pretty much is this 7 or 8 curettes. The first one is just straight curette. The second and third one are angle curettes that are designed to go through the size of the pedicle from medial cortex of the pedicle to the medial cortex of the pedicle of other side. And the angle of the cup is so that by rotating the curette, this will get the cortex or the cancellous bone to the side and away from the fragments. So we are not putting any pressure on the fragment. We're just taking the cortex. It is right and left, basically, which side you go. And then this is a down pushing disc. This sometimes you need for taking the disc. You have had similar to other instruments as well. And this is the disc removal that you can go from the pedicle to reach the disc above. So it is made so you can, by getting through the pedicle, but reaching to the disc. This is a impactor, the elevator that you go and protect the dura and separate the dura between the fragments. And by then, the fragments are very loose. And then you can use the impactor to sometimes you just don't have any, you don't have to bang on it. And you have seen these cases that if you don't create space below the fragments, then you just bang on the disc and the disc comes back. It does just unsuccessful, very unhappy. But if you create the space, this closes like a book. This is just showing you the sawbone. This is transverse process osteotomized and then free, and then create a room for the pedicle. Already the other side has been stabilized, and that gives some correction. And sometimes you can do distraction or whatever to create, but you have to do it obviously with care. And this is the curette that goes inside the vertebral body and try to create that space. And this is just the schematic. And this is the curette that goes and through the pedicle and to get the disc, clean the disc of that. It's already pedicle screws in the other side. Once the medial cortex of the pedicle was removed, the elevator sort of goes between the dura and the fragments, and the impactor sort of pushes down the fragments into the cavity. After that, you can see the fragments that have been reduced, and the end plate of the superior end plate has been cleaned. And these are bone grafts. Some of the techniques of using just cancellous bone graft is really not ideal. It should be a cortical cancellous bone, or I guess some cages can be done as well. I've never used that for this, but used the cortical cancellous bone, and impactor would bring it in and provide some structural support anteriorly if there is a need for it. Obviously, you have to be sure that we know the anatomy, and especially the vascular anatomy, trying to make sure we avoid the vascular underneath the transverse process. This is just another drawing that I have for another book that I thought maybe just review. You can see that the pedicle screw is in one side, the instrumentation is on one side, The pedicle has been buried, the lateral cortex, and then the curettes are used to go inside the body of the vertebra. Here you can see the rotation that I was thinking. It was just rotating this curette. You are taking the bone away from the uh, spinal canal and dura, so you don't really injure. Here is how you create the space. Fragments are here. And here the separation between the dura and the fragments. You can see the posterior ligament, and then pushing the dura back, pushing the fragment back with the um, uh, with the impactor, and then structural grafting. So it's just pretty much that's the technique. You can see the case. It's the 17-year-old with L1 fracture, and you can see by putting the instrumentation in one side, you can get fairly good correction, and then to the other pedicle, you can do this surgery with. In this case, you're just cleaning the disc. Here's the CT scan of the case with the encroachment of the canal, and looking at the space that was provided after that. This is a post-op. This is the old Isola system, where you have the graft anteriorly and the alignment and the short fusion with 5 screws that really gave a good stability. And as the fracture heals, they could be even more stable. We used brace at that time. This is just the paper presented in SRS in 1994, 32 patients, and the burst fracture was basically more at thoracolumbar junction L1 and L2 mostly. There was incomplete patient 21, normal patients 11. And indications in the normal patients was that if it was canal compromise was more than 60%, associated with loss of anterior vertebral height, then we know that it could cause kyphosis, and incomplete patients that is not improving, and if the neurologic deficit is deteriorating. Neurologic results was no worsening of the neurologic function in all normal patients, stayed normal, and 3 incomplete patients remain unchanged, but 18 out of 21 incomplete patients improved. Average improvement in ACL score was 17, 67 to 84. At minimum of 2 years follow-up, the average fusion of 4 levels, patients with anterior grafting, which had 7, all fused. So anyone had an interbody fusion fused, no loss of correction. The CT scan showed 68% canal compromise preoperatively, and postoperatively, showed 15%. They had mild or no pain in 28 patients, and independent ambulator, all 11 normal and 16 incomplete patients. Complications, usual complications: wound infection, 1, UTI, pulmonary embolus, increased kyphosis, 6 degrees, over 6 degrees. 2 were fused, actually, at the 2 years follow-up, and 1 had pseudarthrosis. Implant-related complications, 4, but all fused at follow-up. So in conclusion, I think the posterolateral decompression is a safe technique, especially if you have some posterior suspicion of dural tear. And if it's combined with adequate fusion and instrumentation, then solid fusion and good alignment can be achieved. Anterior grafting with loss of vertebral height, prevents kyphotic deformity, pseudoarthrosis, and implant problems. I think that's pretty much that's what it is. And we talked about the Frankel classification. I just remember any fellows, maybe Amber or Cam, do you know what the are you familiar with the Frankel classification? Hello.
I know Jay had talked about it in his talk earlier this year.
Yeah. You know
when he
who
presented thoracolumbar fractures.
you know who Frankel was?
No, I'm not very good at that stuff.
He wasn't a surgeon. You probably heard about this famous hospital in UK called Stoke Mandeville. Is 200 years old and is the center for spinal injuries. And Frankel was running that hospital, Stoke Mandeville. He was a medical doctor, and there were just patients, in Stoke Mandeville for months, just non-operative treatment of spinal injuries, complete or incomplete. And so he was pretty much against the surgery. And I remember I went there in 19, I think it was 83 or 84, and in Poland, it presented some of the Harrington instrumentation uh, to them, and everybody was yelling at me. So Frankel, actually, we were in Poland, and he was in a train with me, and I was talking to him, just telling him about the thing. It was a great discussion there. But Frankel gradually started to have some serious patients in the stroke man, and even then, probably he was the Society for, it's International Society for Paraplegia. He was the president of that. So, this is a story about Frankel, just a little historical thing. I remember that night we took an overnight train from Warsaw to the south. Okay, questions?
So most of these 3-level fusions, Dr. A, were 2 discs, 3 bones.
Yes.
And
yes.
So when did you think it necessary to go longer than the short segment?
When there was some other, there was no intact vertebra at the top, and there was some other thing, it would go 4 levels. But there was some 5 levels as well. And I think we probably were not making any detailed attention to the sagittal, but it was pretty much short fusion, and being in the thoracolumbar spine, typically is the straight part of the spine, really didn't cause any, long-term problem, at least at patients that I saw more than 2 years. Yeah, mostly was 3 vertebral levels, 3 to 4.
So if there was a lot of comminution at the fracture level, you still thought you could get away with just doing the short segment?
Yeah, I think that was found that putting that structural grafting is important, and if there was a significant comminution that there was end place and not really supporting the graft, then you would go higher.
Gotcha. Cool. That's a great
Yep.
talk. I love the historical context. Thanks for sharing.
Thank you. No, I think that it's something that you have it, and occasionally you can use it. You know that you can do it from one side, and but going in with impactors and just hitting on that fragment, I think you all have that experience, the frustration that the thing would come back, and then you put the more pressure on the dura by doing that. Okay. Any other questions?
And then do you do a full laminectomy? Or do you just
No,
do a,
actually, in the other previous technique that was actually published from UCSD was um, the other technique was going to do a laminectomy, or the technique of bilateral that was published from, I remember where, but they do where that technique involves total laminectomy from both sides, and through the tube also required laminectomy because you have to reach the dura from inside. This will not go that much of a laminectomy, but because all going lateral.
Awesome.
Yeah, that's the difference.
Well, perfect timing, 7 o'clock. Thanks so much. That was a great talk.
Thanks, Dr. A.
Thank you very much. Have a great day, everybody, and great week.
Thank you too.